Good afternoon or morning, depending on where you're tuning in from, or good evening. We have some folks from everywhere joining us today. Thanks for joining. My name is Courtney Malberg, and I am the Associate Director of Education here at CurePSP. I am thrilled to have you all here today to discuss a very important topic that I hope will give some clarity and direction. Today, what can we do? So before I introduce our speaker, I have just a few housekeeping items. One, this program will be about an hour long, including the presentation and the question and answer session afterwards. We'll be answering any relevant questions that you submitted in your registration, but please feel free to type any questions you have into the chat, and we'll try to answer those after the Q&A portion. We're recording this webinar live, but it will be archived on both Facebook and our YouTube channel for anyone to view later. Third, if you had registered for this webinar, you will receive an email with today's slides. And if you're watching this live, we will also put a link in the chat. Lastly, for those watching, and many of you have, please use the chat box to tell us where you're tuning in from. We'd love to know. With all that said, I would love to introduce our speaker. Dr. Federico Rodriguez-Porcel is an assistant professor of neurology in the movement disorders and behavioral neurology. He obtained his medical degree from Universidad del Salvador in Buenos Aires, in Argentina. He completed his internship and neurology residency at Loyola University Medical Center, where he served as chief resident. Subsequently, he completed separate fellowships in movement disorders and behavioral neurology and neuropsychiatry at the University of Cincinnati. He's now the director of MUSC's CurePSP Center of Care and the director of the Aphasia Clinic. His NIH-supported research focuses on cognitive and communication impairment in neurodegenerative parkinsonism. So with that, I'll pass it over to you.
Hi, sorry. Thank you, Courtney, for the presentation, for the introduction. Just so you know, everyone, I'm having some issues with the connection, so I hope I can make it through the whole hour, but I think we're good now. So again, first, thank you for all of you for joining. We have an important topic to discuss today that I know that affects a lot of the patients, but also the care partners and the family. So I hope to provide some guidance. As you can imagine, we could talk about this for hours. So my goal today is to provide somewhat of a framework of how to approach these, and hopefully you'll find it helpful. And then we'll have time to discuss questions. Okay, so we're gonna move forward with the next slide. Okay, so first this is an outline. So we're going to talk about how common this is, what are the things that can change, again, questions you should ask yourself, and the different approaches we can have to dealing with problems with and thinking and behavior. This is not only about the patients, but how it affects other members of the family or care partners. And I'm going to go over some examples with different issues and how we can approach, they can be individually approached. And then we'll leave times for questions and comments. Okay. So let's get started. First, problems with thinking and behavior are common. They're a common issue. Sometimes they may be even the presenting symptom, and sometimes even before you know there's something wrong. But something with the benefit of hindsight, you can say, well, you know what? Now that I think about it, this was changing before I saw the movement disorder specialist, which is typically how where people end up seeing or being diagnosed with conditions like PSP, Corticobasal Syndrome, or MSA. But independently if they appear early or later in the disease, they are usually a feature throughout, like at some point during the course. It can present in different ways. Not everyone is the same, and this is important because it might be that you hear or have seen some symptoms or signs in other people and may think that it's going to happen to you or to your loved one, and that might not necessarily be the case. The same thing goes to treatments that may work for someone or some people that may not work for everyone else. Important thing is that also it affects quality of life, and I think that's one of the things that why it's important to try to diagnose it and also to try to address it in the best way possible. I'm not going to go through the assessment too much. I know that my colleague, Dr. Turner, talked about that some time ago. So I'm going to focus more on, okay, now that we know there's a problem and we have an idea and we can give it a name, what can we do about it? The slide, I think the format has made this slides that are crunched. So when when we think about what can change, I put it in two columns. So one is thinking, and the other one is behavior. When we think about what are things that can change in thinking, the first thing that most people notice, independent of the condition, is that there might be some slowness, poor judgment. Some people become a little more impulsive, and other people notice that they're not able to make decisions as well as they used to. Memory is one of the things that we usually attribute to, and particularly short-term memory problems, and also difficulties with communication. Could be some difficulties articulating words, or sometimes problems getting those words out or understanding what other people are saying. But those are not the only problems that you can find with in thinking. And when it comes to behavior, you can see sadness, depression, sometimes excessive worry or anxiety. One of the things that we're now learning that is more and more common, and actually can affect quality of life significantly, is loss of interest or apathy. Inappropriate behavior can be a big issue, and irritability. And these are some examples, but you can, and there are different ways that this can present, and this is not the only presentations you can see. So let's say you have already defined or noticed that there's something off, something that's different, and in the way you or your or the one you care for has changed in their thinking or their behavior. One of the things that it's important to ask yourself, and things that you should talk with your doctor, are the following things before even thinking about what you should do about it, because learning about, or at least considering these aspects, can be helpful to tailor what may be a good management strategy for the individual symptoms. So first is, when did it change? Is it something that I've been seeing for a long period of time and gradually changing now to cross a threshold where I think there's something that needs to be done about it, or is it something that changed overnight? But that's important, because usually we think that in this type of conditions, the progression is gradual, and things shouldn't change overnight or within a short period of time, like a week. So if that happens, we have to start thinking about something else, something that maybe is making the symptoms look worse, but may not be the condition itself. And things like thinking about if there's any events that associated with that changed are important. So for example, if someone had a big fall and right after that you start noticing some changes, then it might be a good idea to evaluate if that fall caused something, or if it was caused by something else, a new medication, or an infection like a urinary tract infection. The other thing that's important is like, who's the person that this change is affecting? Is it the person itself, the person with the condition, or the family? And again, both are valid, but it's important to know who are we trying to treat, because it's not uncommon that we notice that the care partner noticed something that things needs to be addressed, and the patient really is not affected by it, or is not disabled by it. So again, trying to put medication when no one is really benefiting from it may not be a good strategy. And the last thing is it worth treating, right? Not uncommon that we go to the physician and we want to make sure that we're covering all bases and we're mentioning what's going on, but some things may not need to be necessarily addressed and may need to be monitored. So it's important to understand, like, think about this yourself. It's something that I want to be addressed, or I prefer to hold off. And again, that's the type of thing that you have to discuss with your doctor. I mean, all these things are important to have it in mind before you decide to discuss them. But it's important to discuss them individually with a physician or the healthcare provider that's working in the individual case. And I think that's something that's important that I discuss this with my patients often. It's like, what is the goal? So if we see a change, something that is bothersome, what are we aiming for? What is the thing that we're aiming for? And this is just the way I try to think. And these are what I would say, I'm going to say order of importance, but things that are valuable, but everybody's different. And I think that's one of the keys, that it's not on the slides here, but I tell every patient, everybody's different. Someone may have the goals that apply to someone may be totally different from someone else. These are the things that I think we have to consider, but it's an individual. It's something that you have to know, and you have to establish what are your values, and then discuss it with the healthcare provider. So the first thing is safety, right? If there's a symptom or a sign that could get the patient or their loved ones affect their safety, then whether if it's bothersome or not may be less important, right? If someone is, if someone is very disinhibited and this disinhibition may lead them to say something inappropriate in a public space that may not be understood by someone else, then it needs to be addressed independently if the patient is bothered or the family is bothered by it, right? The second thing is quality of life. If it's something that is affecting your ability to enjoy life in the best way possible, then it's something that needs to be addressed. Then we have things like independence and function, which are also very important. And again, this is where it depends on how important things are for you. In some cases, being able to have some help remaining independent may be more important for some people than other, and the same thing goes for function, right? And so those are things that you have to consider. Like, what is the goal when we're trying to address or manage a symptom? And there are different approaches. But again, I apologize. I think that the format has changed, crunched the slides. So we usually it's a common theme that people think that there's nothing that can be done for conditions like this, and it's true that at this point in history we don't have a medication or a treatment that slows down the progression of the disease, even though we know that exercise can help with that. But it doesn't mean that from what we call a symptom perspective, there are not things that we can do. So I think it's important to know that there's always something that can be done, and we need to try to approach it again. But then it goes back to what I said before: is it something that is bothersome? Is it something that's worth doing something about? And there are different approaches to it. One would be adaptation, and we'll go over different approaches. Adaptation. The other one would be, I call it, activities, medications, devices, and addressing other factors. Okay, so we'll go over. My idea is to go over the general examples, what they mean by each one of these, and then we'll go through different cases and how these can be applied. So the first thing is adaptation, right? So first thing is that whether it's PSP, Corticobasal Syndrome, or Multiple System Atrophy, this changes. And it doesn't matter if you're a healthcare professional. It doesn't matter if you already have an idea of what the condition may be before this starts. This is something that I would say most of us are not prepared to deal with. So educating yourself and understanding what the symptoms are and how to address them on a daily basis is important. There are great resources for this. CurePSP is a great resource, and I'll encourage you to go. I'm sure that I'm preaching to the choir here because you all signed up through the CurePSP website, but looking at the website and the resources they have on how to deal with symptoms every day. And this is some of the things that we can talk about today. So, for example, if someone is irritable, making sure that you redirect them and you assure them, you redirect them. So things like that are important. Then evaluating safety, right? We talked about how important it is to evaluate safety. Depending on what the issue is, evaluating the safety at home. If there are financial risks in someone that is having problems with impulsive decisions, making sure that certain assets that are important are not freely accessible, and subject to scams or to impulsive decisions. Driving, it's a big issue. It's sometimes of a difficult topic to address, particularly in more early stages, because driving is very important and also allows some independence and some activities that we're talking about. But on the other hand, obviously there's a risk. There's an increased risk associated with it. So that evaluation or that consideration is very patient dependent, and also noticing what the individual case calls for. I always tell people that, and when people come to my clinic, is that I don't have the ability to assess if you can drive or not. I mean, there might, depending on the situation, I might have more or less concerns. But if there's a doubt, having a driving evaluation is always a good idea, where they do use a simulator, and something it doesn't necessarily mean that they're going to take away your license. Some states like South Carolina don't allow you to do that, but at least they give you some recommendations on how to on if you're allowed, if you can still continue to drive, maybe some certain limitations, or If it's not a good area for you to try, they'll tell you that. And obviously, exposure to unsecured firearms is also something that needs to be considered. Again, resources. One of the things that is important is that we can always use more help, right? And this condition, particularly these type of conditions, as they advance, you require help. So it's never too late to start looking at what resources am I eligible for. Talk with a social worker, talk with your insurance, and know what are the things that they could be able to help you with and pay for, right? And also look at foundations, like CurePSP, for example, as opportunities for respite care and support groups. All those things are important. So that's part of adaptation can be important, right? Activities, things that are, I think, there's certain activities that are part of enjoying life, right? And sometimes when you have some limitations caused by the condition, it might be difficult to continue with those. But it's important to maintain a routine, right? I think that scheduling activities is a good idea. I always tell the same example. If I'm sitting lying there watching TV and one of my kids asks me if I want to play, and the first question is probably not, because I want to relax. But getting things done in order to get in, pushing yourself is really helpful. So scheduling activities it's important. We'll talk about that a little bit when it comes to apathy. Focus on things that you enjoy. There's a balance. There are certain things that can help you, but in the end, I think it's a good idea to find a balance on things that you enjoy. So if someone, I don't know, if you hate running and you rather go do power walking, do that. That's okay. The exercise, for example, is the one that you're going to do, and things that you enjoy. And all of this is about giving you quality of life. So don't force yourself to do something that you really hate. If there are good alternatives that you enjoy more. New hobbies, trying to pick up new hobbies and minimize distractors. So try to focus on doing one thing at a time. Those are things that I think are important. Therapy. Depends on the situation, obviously, but having physical therapy, occupational therapy, and speech therapy depends on the condition. But those can always provide something helpful and new strategies. You may feel, how they're going to help, but it's important that to do it in certain situations, talk with your healthcare provider about that. And it might be that you don't feel that necessarily makes things better, but if at least it slows down decline, can be helpful. And sometimes in the case of physical therapy, when people have a lot of apathy and don't want to get out and do things, it's a good opportunity to schedule things and get some activity. And then lifestyle modifications, aerobic activity. Yes, I'm not a doctor telling you that aerobic exercise is good, but it is, and we have evidence that it can be good for you. Obviously, making sure that you're safe. And staying cognitively and socially engaged as much as possible. So those things are important. Those activities, again, when I see patients, I think that the ones that do better are the ones that focus on things like these activities. Then medications. There are two aspects to medications. There's a good aspect and a bad aspect, right? So I always say that probably the patients that are happier with me are the ones that I took them off medications than the ones I put on certain medications. It's not uncommon that, again, when you go to your healthcare provider, you have some complaints, some issues, and sometimes the low-hanging fruit is to try a medication, and then people end up with tons of medications that they don't need, and they're not sure if they work or not. So it's a good idea to go over the list and think, tell yourself, do I really need this? Why am I taking this medication? Could it be decreased or could it be removed? Particularly, there are certain types of medications that have sedative effects that can affect memory and thinking. So benzodiazepines are a well-known medication, like medications like clonazepam or diazepam, things that sometimes people take for sleep or for anxiety, and maybe they took it 4 years ago because there was an event and they never stopped it. So trying to remove those medications, again, there's not going to be a magic pill that makes everything go away, but at least working on those different factors can improve function and quality of life. And again, other medications that have side effects, like levodopa is a common medication that we prescribe, and it can help, but also too much can come with side effects. So trying to evaluate that, particularly if you notice that right after you take a medication or within an hour of taking the medication, there's a symptom that you don't like. For example, in multiple system atrophy, it might affect your blood pressure and cause you to be a little more fatigued. But then you have to consider other medications. There are certain medications that can be helpful in certain situations, and it's important to consider them. Things like antidepressants. There's specific types of antidepressants like serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors that can be helpful for symptoms like anxiety, apathy, and disinhibition. So again, it's important to consider those in individual cases, and other things that like mood stabilizers can help with impulsivity. When it comes to medications that we sometimes use for Alzheimer's disease, like they are called cholinesterase inhibitors or memantine, there's not a lot of evidence that they're helpful, and sometimes in some cases it can be detrimental. So I usually don't use those unless there's a specific situation. I don't know, there's a Corticobasal Syndrome that I think may be more related to Alzheimer's disease rather than to other conditions. Okay, so again, it's important to look at, when you think about medications, looking at not only medications that you can add, but also which ones can I take out that may be detrimental. And again, it's something we have to analyze every case individually. Then devices that are also helpful, and they can also, this could go part of adaptation. Thinking about daily planners, things that can help you maintain a schedule and keep up with activities that you want to do. Mobile devices also now can be very helpful with activities, and also to stay up with activities, not playing mobile phone games, but it can also help with taking medications and reminders. And when it comes to communication, and we'll talk about this a little bit later, there are things like augmentative or alternative means of communication that can be helpful, particularly when there's difficulty getting words out and communicating. Things like writing is obviously the most obvious one, but there are others like an alphabet board or text-to-speech devices, or voice bank, where you when you notice a decline, before you notice a decline and you're not able to talk, you save your certain words with your voice in a voice bank, and then you can use that later to communicate. And then eye gaze speech generating devices that can be also available and worth considering if speech is one of the main issues. And then addressing other factors. The fact that you or your loved one has a PSP, CBS, or MSA doesn't mean that there cannot be other things happening. And we talked a little bit about this before. So looking for infections. So if someone has a urinary tract infection, the symptoms may look much worse, and they might not be able to identify the issue. And so that's one of the first things that we look for, particularly when there's an abrupt change. Pain. Sometimes, particularly in Corticobasal Syndrome, there's this dystonia that becomes painful. That can affect memory and thinking, and also it can make people a little more irritable. So you want to make sure that there's, and it may not be even related to the disease itself. If someone had a fall and has a small fracture, has an injury, that itself can be an issue, and it's worth addressing. Things like alcohol, never a good idea to so there's the best amount of alcohol is 0, and so trying to limit intake and maybe as much as possible. Sleep, like improving sleep quality. Yes, there are medications that can help you sleep better, but usually what they do is they make you a little bit drowsy, and those can affect memory and thinking and balance at the same time. So it's always a good idea to try to focus on what's called sleep hygiene. So trying to avoid watching TV in bed, try to have a routine before you go to bed, avoiding screens, avoiding things like drinking coffee later in the day. All of those things that can help improve sleep quality. If you snore, it might be a good idea to evaluate if you have a condition that's called sleep apnea that can be treated. So things like that are important for sleep quality. And then other things like hearing problems, right? If someone has hearing problem, communication might be difficult, and you might think that they have a problem with memory and thinking, but they're just not able to hear as well. So considering if there's hearing aids could be helpful. And again, other medical problems. If someone has poorly controlled diabetes, then no matter if they have PSP, CBS or MSA, the symptoms will likely look worse. And again, things like blood pressure, which can fluctuate, particularly when it comes to multiple system atrophy, may be worth addressing. So again, looking at the whole picture, trying to look what else could be going on and what else can be addressed. So a lot of what we do is focused on, the way we discuss is, well, how we can help the person with the condition. But it's important to know that this condition affects others, right? And there's usually a care partner. It can be a spouse. It could be a son or daughter, or it can be a relative, or maybe even be a friend. And they are also affected in some extent, right? I think people are affected in different ways, or in a different way. No one is prepared for this. I would say that even those of us who have studied this in the books, if you have a relative, that all that knowledge kind of goes away, because no one is prepared for this. Maybe someone may be prepared from an intellectual perspective, but never from an emotional perspective. And there are challenges that present every day, right? So it's important to recognize that, and it's important to try to avoid what's called care partner burnout, right? So signs of that could be a losing temper, feeling overwhelmed, and the important thing here, and I think maybe this is one of the things that I want to stress here, is that that care partner burnout does not affect only the care partner, but it will also affect the person with the condition, right? So if you're overwhelmed and frustrated and you don't have any energy, it's going to affect the person you're taking care of. So it's important to take care of the care partner. And by doing that, you're not being selfish, right? If you're a care partner listening to this, you're not being selfish. You're actually taking care of the loved one as well, because if you're burned out, something's going to fall through the cracks. There might be some issues. So it's in not only your best interest, but also the person you love, to take care of yourself. And things like the strategies to do this is taking time, right? If someone asks for help, if you need a break, or you need to go out and do things that are personal to you, and you can ask for help, and someone is willing to cover for a couple of hours or some a more extended periods of time, and you feel you need it, it's okay to ask for help. And again, asking and accepting help. Sometimes I tell people that the best way to help others is by letting themselves be helped. Sometimes, like struggling, it's something more burdensome to try to get someone to accept help than to provide the help itself. So things like that, I think, are important to consider. So now I'm going to go through some examples, applying those different principles to different signs and symptoms that I've seen in the clinic, and then we'll wrap up and have some time for questions. Okay. So, for example, communication difficulties. So when people have difficulty either articulating the words, so they know what they want to say, but it comes out difficult to understand. It comes out slurred, or they have difficulty forming the words. There are different strategies you can look at here, right? So when it comes to adaptation, giving yourself the time to communicate, not taking a rush, and the care partner also, again, giving the other person time and saying, like, it's okay, we have all take your time to communicate, because that if we add anxiety or worry or pressure to that, it only makes it worse. Things like giving options. So if someone is trying to say something and you feel they're struggling, you kind of know what the topic is, you can give them options of what they're trying to say, and sometimes people respond better to options. Again, writing is also an option as well. Obviously, the low-hanging fruit is obvious. Having speech therapy, not only for techniques on how to articulate better and to communicate better, but also it can help with devices, which we're going to talk about a little bit later. Medication, things like removing sedatives, right? If someone is very sedated, is taking a ton of medications, and the brain is not going to be working as well, and they might need to get, and that could contribute to the difficulties communicating, right? Getting the words out. Devices, as I said before, can be very helpful, particularly if you notice early in the course of the disease that communication may become more of an issue. Thinking about developing a voice bank, or starting to use a tablet or or text to speech devices. And finally, hearing difficulties, right? If someone has hearing problems, you may feel that they're slow, or they have difficulty processing, but maybe just because of their hearing problems, they need an extra time, or they need more I would call it mental bandwidth to process what they're trying to say. So all those things are factors that are important and can be and are addressable. Next one is apathy. So when I refer to apathy, it means having loss of interest. So people that used to have hobbies and interests and want to do something, and all of a sudden they find themselves less interested. Yes, there might be a part where the disease itself, the motor aspect of the disease, limits them, but they still, even if they could do it, they will not be interested. And we're recognizing that apathy is a big issue, not only for the patients themselves, because obviously if you don't use it, you lose it, but also for the care partners and their families, because now the people are not, the patients are not, the people with the disease are not active, are not participating as much, right? So first thing is the adaptation is education, right? So for you as a care partner, for you as a patient, understanding what's going on, what are the things that you can do about it. And I think one of the things I usually recommend are scheduling activities. As I said before, if you're asked like on the spot, do you want to do this? Do you want to? It's likely that you may say like, no, I don't want to, or I have other things, but if you plan it, if you know ahead, then you're going to do it. So having scheduling activities, and a good way of starting is starting small. So if the person you love doesn't want to do anything and you feel they're sitting down watching TV all day, a good way of starting would be like, okay, let's schedule something out. Every Wednesday at 10 a.m. we'll go for a walk, and you start small and then gradually increase it, the level of activity, until you get to something that's reasonable. I also think it helps not only the person, because you say, well, I did this, then I'm free, I can do whatever I want after that. It also helps the care partner saying like, we accomplished something, and then you can gradually adjust it and increase it as much as you like. Medications. So when it comes to, sometimes antidepressants can help, but it also can make things worse. So you have to be mindful of it and watch them. Stimulants, there's some case reports that suggested some benefit. Again, I take those with caution, and it goes back to first trying to do things without medications and see if those come to an acceptable level. Worth discussing always. So things like something like Ritalin or modafinil can be have reports of success, and in some patients they do help. But again, you have to always like case limited series. It's not like a trial that has shown a specific benefit. Again, go back to the same topic, removing, right? If you take a ton of medications that is sedating you, then you will not want to do anything. So think about removing that may be even the first step. Daily planner, as I said, with activities, scheduling activities, also things like sleep quality, because if that affects your level of energy, you want to try to address that. Slow processing, again, it's along the lines of communication apathy. So education, having the family and the people that interact with a person understand what's going on, and then taking time to communicate. Activities like socializing and staying cognitively active, those are important. I think that sometimes people have concerns about interacting and say, well, I don't want to embarrass myself. And I tell I think human beings are more understanding and nicer than we give them credit for. And so if someone has a problem, usually they'll work with them, and particularly if someone that you know already, they'll they'll engage you and take your time. It's a good idea that in this case, when you're socializing, if you notice that some problems with slow processing, if there are problems with communication, to try to stay maybe on one-on-one conversation. Sometimes like group discussions can be a little overwhelming, and if they're slow processing, you may not feel they're fast enough to interact. Medication, medications like dopaminergic medication like carbidopa, levodopa, or other dopamine agonists can be helpful in some cases, but also can be detrimental. So also trying to see if that needs an adjustment. Depending on the situation, I might try to go up and see if I made it better or worse, and then if not, I go the other route. For slow processing, also reminders or notes and other factors like sleep quality, hearing impairment, and like, for example, multiple system atrophy, you can have low blood pressure, and that can affect your memory and your thinking. So seeing if your blood pressure is fluctuating up and down, that could be a factor playing a role here. Disinhibition, not uncommon in conditions like Corticobasal Syndrome, but also more common in PSP. This is one that where education and for people that interact with the person need to understand that those acts are in a that are uncommon or for that person, or maybe inappropriate sometimes, are not a reflection of what the person is, but a reflection of the disease. Things important like assessing safety. Again, if there are guns at home, if there are financial risks, if they have access to quantities of money, those are things that are important to try to address and adapt to if needed. Things like therapy, like physical therapy, and even sometimes speech therapy can be helpful to get the person interacted and redirect them. Medications, like in this case, medications like dopamine agonists and also carbidopa-levodopa can exacerbate the symptoms. So if someone's taking a large dose and or even a low dose, it might be worth seeing if they do better without it. In this case, medications like antidepressants, particularly things like citalopram, and can be helpful. Mood stabilizers also can be helpful sometimes, and with antipsychotics in more extreme cases can be thought as well. So the important thing is try to, I think the medication will depend on the situation, right? Some cases, if the disinhibition means, I don't know, saying every now and then, saying that someone has a weird hat, it's one thing. Or the other thing, or when people have more inappropriate comments that could be punished by the law. So that depends on the situation, and also that depends on what type of medication you're going to use, or if you want to use medication. Devices like safety alarms are also important, but not only for the person itself, but also for the care partner in cases where things where safety may be an issue. And other things like alcohol intake and poorly controlled diabetes also can worsen symptoms of disinhibition. And irritability, adaptation, for everyone to understand what's going on. Safety is important, particularly if you're living with a person and that person can cause some harm to them or to others. Avoiding triggers is important for activity. So if someone gets very frustrated or very angry when you do a certain activity, trying to adapt to that. In this case, again, reducing sedative or stimulating medications. If you're taking a lot of medications that make you drowsy, that may make you more irritable. But also if you take a lot of stimulants, right? You're trying to address apathy and you give someone a stimulant, all of a sudden they're more irritable, then you need to take them off. And medications like antidepressants, in this case, citalopram, can be helpful. Again, a safety alert and also factors like sleep are important. So this is just a nutshell. I just wanted to give you some principles. And again, to finish, I want to make some final comments. This is by no means a comprehensive approach, right? Everybody's a bit different. It depends on the person. So things that may have worked with someone may not work for you or for your loved one. And also, everyone has different goals, right? So you may say, look, I want someone to be happy, and well, whether if they're in a wheelchair or they walk, that might not be my biggest goal. And for some people, may say, look, I just want to walk because I want to make it to my daughter's wedding, and then the goals may be different, right? It's important to ask for help. Like, always ask for help. There's people there that want to help, and believe it or not, people in healthcare don't read minds. So if you don't tell them, they will not know. So it's important to ask for help. But the important thing to know also is that there's no magic pill. There's not going to be a pill that makes everything go away. And all these factors individually may not lead to, if you take them all individually, each of them may not lead to a massive change, but all of them together can make things much better and tackle the problems from different angles. Again, adaptation activities, medications, devices, and other factors. And also, an important thing, no matter if you're a patient or if you have the disease or someone you love has the disease, take care of yourself, right? And be kind. Know this is a challenging condition that affects you in many different ways. And as long as you're doing everything that you think you can be doing, and that's why it's important sometimes to ask the healthcare provider, am I doing everything I can? And that itself should be some sort of relief, right? If you're doing everything you can. But be kind to yourself and take care of yourself. So with that, I'm going to pause. And this is our team. And I just want to thank CurePSP for having me present today. So happy to take questions and comments.
Great. Thank you so much. That was very educational and a lot of and fantastic information was given. I just have some questions that I'll ask you that came from the registration and also some relevant conversation that was in the chat. So the first question I'll ask you is, what symptoms should people with these diagnoses expect when it comes to UTIs? I know that's a big topic and not everyone knows what it's for.
And so what I would say is that this, when you have like a UTI, you can expect maybe underlying symptoms to get a little bit worse. So if I had to think, I would say maybe some slowness in some people, particularly if they have, I would say if they have multiple system atrophy, they may be a little more confused and they will have this waxing and waning level of alertness. So I would be careful with that. What I would say is that anytime you say like, oh, this is a big change, the first thing that should come to your mind is not, oh, the disease has caught up with me or has caught up with has caught up. It's something else. You have to look for it and trying to understand it. It could be getting some infectious workup. It can be looking at doing imaging of the head to see if there was a fall that caused some sort of bleed. So those things I think are important.
Makes sense. And when it comes to UTIs, do you think that most healthcare professionals that aren't specialists in this area know to look for UTIs when symptoms are advancing quickly?
I would say I would expect yes.
Okay.
If people have dealt with neurodegenerative diseases, but I also will say that people need to be their own advocates.
Mm-hmm.
And I say this as I think someone who has decided to practice in a very narrow field, and it's if you don't ask for it, if you think that this could be a UTI, I think it's a good idea to ask about it. And maybe the healthcare professional says like, no, I don't think it is, or we looked at this in the past and it's not been the case. They should be able to give you an explanation why. But it never hurts to ask. Don't expect that they're taking all this into consideration, right? So just ask.
Yep, that's helpful. I've heard similar stories, so just wanted to confirm that. All right, the second question I'll ask you is, what healthcare professionals should someone seek out when they're noticing thinking and behavioral changes? Is there a specific one?
That's a good question. So in the field of neurology, we have different subspecialties, right? So we have people that go and do movement disorders, some people that go and do cognitive disorders, some people that do autonomic, and it varies from the specialties. And the problem with this type of conditions is that they have a little bit of everything. So usually when you look at PSP or Corticobasal Syndrome, they're probably more attributed to in movement disorders. In my case, I did movement and cognitive, so I do a little bit of both. I would say you can. Usually we start with the most common approach is that you see a general neurologist first. But if you already have a diagnosis or you have a suspicion, it's a good idea to see maybe a movement disorder specialist, or if you find a cognitive neurology specialist, you can see that would be also a good way of starting.
Makes sense. Great. All right. The next question is there any clinical evidence that art and other creative pursuits can help with these types of symptoms, or even non-clinical evidence?
No, and this goes back to the idea of staying busy, right? And busy in the sense of staying active. I love to watch TV, but watching TV is the worst thing. It's in this case, it's not a good idea, right? You're sitting down and you're passive, and yes, you may or may not be paying attention to it. But when you're active and engaged, that also keeps the brain active. And the way I like to explain it is that it's like having different. If you have a town and you get from point A from point B, you're only used to doing one thing, and you have like a big highway to get from point A to point B, and doing activities that are off. What you have done is like develop different streets around it. So if that highway is affected, then you have other ways from getting to point A to point B. But if you don't do other things or alternative or engage your brain in alternative ways, it's gonna be challenging. So you're kind of developing new pathways in your brain that can be helpful to create resilience, and that's one of the things that a lot of these things with activities do. So that's why I strongly encourage them. Again, it goes back to the idea that if someone hates, I don't know, to dance, which some people may do, I wouldn't force them to do it. But if something that like, oh, I always like to, I'm a horrible painter, but I would love to learn how to paint, like, go and do it. That's okay.
Yeah, that makes a lot of sense. Let's go a little bit back to apathy. I think I'm seeing a lot of questions in the chat related to things apathy related. I suppose part one of my question is, do you have strategies for when people don't even want to get off the couch? And then two, is there another healthcare professional you would point them to if that's not necessarily your specialty?
That's a very good question. So usually my strategy, and I'm biased by this, right? Because usually when people come to the experience I'm talking about, people that come to the clinic. So when people come to the clinic, they, at least most of the times, it means that either they care about getting the patient, right? Either cares about getting better, or they are doing it for the spouse, the son, the daughter. So that's where I try to angle this towards, and I say, well, you're here, you want to get better, or at least you care about the person that's sitting next to you. And the way I like to phrase it, like, we can start small. Again, you give them something that's so easy that they can barely say no to, and you say, again, I'm going to give this example, and for some reason, for some years, I always say Wednesday at 10 a.m. Wednesday at 10 a.m. we'll just go for a walk, and that's so easy to do. That's, no one will say no, and that's how you start. That's the strategy that I feel has been helpful. Then there's always, if there's something that people are interested in, and they like to eat ice cream, or they like to watch a show, or you can give more incentive. The problem is that sometimes when people have apathy, those incentives don't work as well. But at least you start with that. And I think it's also learning when to pick your battles. If someone, as the care partner, is constantly trying to get someone to do that, you lose force. So if you focus and say, again, we're going to do it like once a day, 1 hour, focus on this, and we get it done right, then I think there's a higher chance of success. And when it comes to seeing a specialist, sometimes I think oncology psychiatry can be helpful with this, particularly if someone has a diagnosis of a psychiatric condition, they're taking medications that as neurologists may not be so confident removing them. It might be a good idea to, I think it's always a good idea to have psychiatry involved in one or the other if you feel that they could be helpful.
Yeah. Okay. It sounds like a lot of trial and error for each individual.
And I think that you have, and that's the part that was sometimes challenging giving this type of talks, because everybody's a little different, and you get to know the person. And yes, unfortunately, I tell people it's unfortunate. It's not that I can do a blood draw and know exactly what's going to work for you. You get to know them, and there's things that work, things that don't work, but it's important to keep trying.
Yeah. Okay. Thanks. Next question. What are some things to watch out for when observing someone's driving? Are there things that you should note changing in thinking and processing?
That's a good question. So the way I like to say, so if someone changes the way they drive, that should be the first thing that should make you think about whether it's, so for example, if someone starts driving really slow, even you say, oh, they're more cautious, that tells you that the person may have perceived something. Obviously, if you notice that they are now stopping, like braking too close to another car or a light, that's also something that you have to be concerned about. Parking, if you notice like small fender benders or car crashes, those things should be a warning. The way and again, I'm talking this as a clinician, if you as a care partner start being somewhat concerned about sitting or having someone else go with that person, then that definitely needs to be addressed. And again, I think it's never too late. And the way I like to discuss this is that, yes, driving is important, and something bad could happen. And if it's something that would happen that would affect only the person there, and they decide to go, then that would be a different discussion. The problem is that on the road, there's a lot of people that could be on the road that are not part of that discussion. So I think it's important to take that into consideration. It's a balance, right? I know that sometimes I always say that our job as clinicians can be very easy, right? If you don't want anything bad to happen to you, we say just sit down there and do nothing, and nothing bad is going to happen to you, but nothing good is going to happen to you. And the idea of all this is to bring quality of life as much as possible in the context of this condition.
Absolutely. That kind of leads actually perfectly into my next question, which is do you have any recommendations on how to speak with somebody who isn't observing changes in driving or isn't observing changes in cognition and thinking? How do you kind of bring that up to them sensitively?
So you're talking about the patient, or you're talking about the patient?
The person with the diagnosis. How can caregivers and care partners bring that up when they're not seeing it themselves per se?
So I think it's important to start noticing and maybe bringing up certain tasks that the care partners notice that the patient was able to do before and now no longer cannot do it, and looking for specific examples. I think obviously it can be difficult to have those conversations, and the context is important. But I think talking about this and making the person understand why you're having those conversations, and I think I think framing it in the sense of safety, right? When I would talk about driving, the first thing that always comes up is that you don't want to hurt anybody, and we all agree on that, right? So that makes the conversation of driving easy, because it's not that someone's telling you not to drive because they don't want you to drive. It's because you don't want to hurt anyone, and that's something that there's a common ground. Or we don't. Or you can say, well, this, I don't know, our savings, our retirement fund is important for us, right? Yes, of course, and we don't want to waste it. Okay, good. So we've been noticing that you being, I don't know, you fell for a couple of scams, or you're spending X amount of money in cigars. So that's when starting with a common ground and understand and making sure that the person understands why you're saying this, and it's something that doesn't only affect them, it affects you as a care partner, but also affects them. So and then maybe start to say that things that you notice, and usually you have a relationship with that person, and what the love and the care is not in question. So they know they probably know that you have your best interests. They have your interests in mind. So I think that's a way of phrasing, and looking for specific examples can be a good idea.
Yeah, factual examples. That's good advice. The next question is, what do you think about cognitive testing? Somebody mentioned in the chat that speech impairment can sometimes obscure cognition and changes there.
Very good question. So yeah, and again, one of the things that I didn't want, I tried to focus on the addressing, but I think that's important, right? So that's a good point that I maybe should clarify a little better when I was giving the talk. It's important to understand what's really going on, right? Mm-hmm. So for example, I'll give you a good example with the apathy, right? Some people may say, well, apathy is they just don't want to do anything. Well, the subgroup of patients that have apathy, it's not that they don't want to do anything. They just don't know how to get started. So if you realize like, oh, once they get started, they can perform, then you know what your strategy is. Or maybe some other people, like, they just don't feel the reward. So maybe you have to look somewhere else what the reward is, or maybe you just need to schedule things or change the reward. And some other people may have depression, or some people may have problems with memory and thinking. So that's where things like cognitive testing can give us some help. Some people may be more irritable, again, because they notice that their memory is failing and they just don't understand things as well as they could. So trying to understand what's the nature of it. Is it something related to memory and thinking? Memory, is it like a purely behavioral change? Or is it something related to other factors, like I mentioned before?
Mm-hmm. That makes sense. And then you briefly talked about aphasia. I'm wondering if you can just kind of connect how aphasia relates to thinking. Just you did say this, so just maybe mentioning it just a little bit more.
Yeah, well, I could talk about this forever. So when we think about problems with communications, we can think about the issue in three different phases of the word coming out. Right? So when we think about aphasia, we focus mainly on the thinking process that goes behind coming up with a word, processing it, even putting it in a sentence. Then we have that's one extreme. The other extreme, we have dysarthria, where it's the muscle movement, right? And where you have the word, the program, the word or the thought process is there, but the part of moving the muscles themselves is affected. And then there's something in the middle called apraxia, where the motor programs to articulate are not preserved. So in these type of conditions, particularly I would say in PSP, you can see all of them. So it's sometimes difficult to know if someone has difficulty forming the word. I mean, and they're still related. If the problem is they know what they want to say, but they just cannot get the word out, or even if they could get the word out, they have difficulty coming up with the word, or even forming the process. That's where I think it goes back to the previous question about memory and thinking. There are certain, and that's where having an evaluation and understanding what really is going on, getting to define the issue, which again, if I had to go back to the talk, I would say trying to define what the issue is, getting a good assessment before acting out and starting to do things is a good idea.
Great. Well, I'm aware that we have used up our time, and that's all the questions I have for us. So if you need to go, drink some water before your next meeting, you've been very gracious to give us the full hour, and I appreciate it.
My pleasure. Thank you very much for having. Again, one thing is that everybody's a little different, and people are there to help you. So I think it's important that you ask for help, and people will be out there to help you.
Great. We appreciate your time today.
Thank you.
I just have closing remarks, everyone, so don't leave quite yet. All right. That was fantastic. I hope that everyone learned something, or at least, has new things to research and ask their practitioners about. And if we didn't get to your questions, I know there were a bunch in the chat that we didn't have a chance to get to. Please feel free to email us at info@curepsp.org, and we will do our very best to get back to you. That's now in the chat, and so please feel free to reach out. And some big exciting news, we will be having our first ever webinar in Spanish. It will be held on September 11th at 12 p.m. with Dr. Julio Rojas, and it will be on care recommendations for people with PSP, CBD, and MSA. I will note, again, that's in Spanish. However, once it's on YouTube, the recording, there will be captioning available in English if you would like to check that out. You can learn more and register in the link that was just put in the chat. And as a reminder, you can check out our CurePSP YouTube channel and Facebook page for a ton of archived content. I also want to encourage you to check out our whole website for educational programs, support groups, resources, and grants we have available. And lastly, we are only able to offer these webinars and resources because of your support. We hope to see you soon, and have a great rest of your day or evening.